consuming investigation which really is not suitable for everyday practice. But you don't have to be a genius to work out that your patient actually has insulin resistance. And all the clues are given in this slide. Central body obesity and the abnormal lipids are the big clues to insulin obesity. People have talked about, or it was mentioned in earlier slides, that how do we diagnose metabolic syndrome? There are various different criteria which are being used, but abdominal obesity is certainly very important, and looking at waist circumference. And this actually, I think the next slide points out that the waist circumference, which is appropriate to be used in America and Western Europe, is not necessarily appropriate to be used in India and other Asian countries. But in America, if the waist circumference is greater than 40 inches for men and 35 inches for women, triglycerides greater than 150 milligrams per deciliter, HDL cholesterol less than 40, blood pressure elevated, and fasting glucose. Those are the criteria which people generally look at, and if you have any three of those, well then that's one way of defining metabolic syndrome. The strict definition, of course, is important for epidemiological and research work, but from a practical day-to-day point of view of managing patients, as I say, you can look at those things. They're not particularly difficult to measure and don't need particularly high-tech equipment. As I've said before, waist circumference, there is some ethnic diversity in this, and you can see that in South Asians, it's recommended that the waist circumference greater than 90 centimeters for men or greater than 80 centimeters for females, women, is what would be defined as abnormal. And in impaired glucose tolerance, you do get this increased central obesity. Much of the increase is abdominal fat, which is signified in the yellow here. Liver seems to be floating free and doesn't seem to have too much fat in it. Of course, that's totally wrong, because a lot of these patients will also have fatty infiltration in their liver. And what you want to do is really try and reduce the amount of fat in the abdomen. Glucose tolerance categories, again, this was touched on a little bit earlier. You can look at the fasting plasma glucose. And as was pointed out earlier, some of these definitions are really arbitrary, as Adi Mehta pointed out. The 126 milligrams per deciliter for a fasting glucose definition of diabetes is based on the fact that it's about that level above which one starts to see a takeoff of retinopathy starting to develop. Perhaps even more arbitrary is the 100 milligrams per deciliter. A lot of patients ask, what's a normal fasting glucose? And I tend to answer, well, we have arbitrarily decided that anything over 100 is not normal. But I also tell patients, I'd sooner have a fasting glucose of 80 than 99, even though both would come into the normal definition according to this slide. So fasting glucose really is a continuum, and I don't know that anyone can say there's an absolute break point below which you're absolutely normal and above which you're abnormal. When we look at the 2-hour plasma glucose, and these have been rehearsed earlier today, greater than 200 milligrams per deciliter after a 75-gram oral glucose tolerance test is one definition of diabetes, or a random glucose of greater than 200 in a symptomatic patient is also accepted as a diagnosis of diabetes. And then this band of between 140 and 200 milligrams per deciliter defines impaired glucose tolerance. And of course, both impaired fasting glucose and impaired glucose tolerance are halfway points, if you like, or intermediate stages on the continuum from having absolutely normal glucose tolerance to becoming diabetic. Now, the prevalence of diabetes, both diagnosed and undiagnosed, and this again is from the United States. United States, of course, has many ethnicities within it, and this shows that, in fact, there are groups within the United States who are clearly at much increased risk of developing diabetes and metabolic syndrome than others. And people from my ethnicity, Northwestern European, in case you hadn't worked it out, it's an Irish accent that you're listening to. So we tend to be the least at risk amongst the various groups living in the United States, whereas virtually every other race or ethnicity which has migrated into the United States seems to be at increased risk, and Adi Mehta went into some of the reasons for that earlier. And this shows that Mexican Americans certainly have an increased risk, one of the highest groups in the United States, and that amongst men, impaired glucose tolerance and impaired fasting glucose is a greater problem than in women. Black population in North America also is at increased risk of type 2 diabetes. And you can see this is just another way of looking at the problem. If you take non-Hispanic whites, which essentially means Northwestern Europeans like myself, we have the lowest prevalence of type 2 diabetes, and then all these other groups are increased. The Asian American, I think, is a bit of an underestimate at this stage. Now, how likely is one to progress from having one of these pre-diabetic categories is the subject of debate. Some people, if they intervene, can actually go back to normal glucose tolerance instead of progressing to diabetes. But you'll see here that it's saying that the progression to diabetes from impaired glucose tolerance is about 6 to 10% per year. And the cumulative incidence of diabetes by 6 years may be as high as 65%. But that I think, can be modified by the action that one would take. About half of the patients who have impaired glucose tolerance actually meet criteria for metabolic syndrome. And the importance of trying to prevent progression from metabolic syndrome or impaired fasting glucose or impaired glucose tolerance to type 2 diabetes is that once you have actually crossed that threshold and have developed type 2 diabetes, it just about doubles your cardiovascular risk in comparison to what was already an elevated cardiovascular risk compared to the general population. And in women, in fact, when you make that progression from abnormal glucose to real diabetes, it has an even more profound and marked impact on the risk of cardiovascular disease. So here's some more epidemiological data showing that